Mr. Chairman, dear colleagues, ladies and gentlemen, I would like to express my thanks to the organizing committee and to the medical group for this kind invitation. And also my special thanks will go to Professor Ruse and Madjo for his hospitality and for his friendship. My talk will be on the past, present, and future of laparoscopic colorectal surgery. The laparoscopic surgery started with cholecystectomy in the world, and they started to do in 1980s the first laparoscopic procedures. But in 1987, Dr. Philippe Mouret from France was done the laparoscopic cholecystectomy, and the honor is going to Mouret in 1987, and the procedure was named as the Second French Revolution. And the other part of the body, for example, hiatal hernia, inguinal hernia, adrenal, spleen, and colon and rectum, the pathologies start to be treated with laparoscopy. And the adoption of new technologies varies with the practitioners, because innovators start earlier and they create the new technology. The pupil is risk-oriented, and early adopters follow these innovators in the early period of the new technology. And then this is followed by more conservative but open to new ideas people. These are called early majority. And the technology is adopted later on by fairly conservative people, but some others are not doing this surgery at all because they are change averse. At the beginning, there was a resistance to laparoscopic surgery because of the insufficient visualization systems, because of the inadequate tools for dissection, vessel control, and anastomosis. And during the learning curve, the operation time was long at the beginning, and we saw some organ injuries during the procedures, and the conversion rates to open surgery was high really at the beginning. But the major concern about laparoscopic surgery for treating cancer cases was the port site metastasis, and we know all that this is not a case now in our era. The first paper published in 1991 in Surgical Laparoscopy and Endoscopy Journal, minimally invasive colon resection with laparoscopy, and the Jacobs and colleagues published a paper. They included 20 cases, and as you can see here, there are hemicolectomies, right, left, sigmoid, and also some abdominal perineal resection. Some patients, some surgeries were done for benign diseases, some others for malignant. And the length of stay is really acceptable. The median is around 3, 4, 5 days. It's not too long. And this is the first paper published in the literature. I like very much these sentences of Arthur Schopenhauer. All truth passes through 3 stages. First, it is ridiculized. Second, it is violently opposed. And third, it is accepted as being self-evident. This is a video in 1993 in Istanbul during the endoscopic laparoscopic surgery congress. I take the parole, and then I'm opposing doing laparoscopic colorectal surgery, and I'm criticizing who are doing laparoscopic colorectal surgery 30 years ago. But we know all that the famous studies, randomized controlled trials, were published at the beginning of the 20 millennial. USA COST study, Europe color study, and UK classic study. They compared open and laparoscopic surgery in terms of oncologic results, and there was not any statistically significant difference in terms of oncologic results. And for that reason, after these randomized controlled trials, the laparoscopy became an important tool for treating colorectal patients. And these are the results of surgical care outcomes assessment program from USA, and they evaluated the regional uptake of minimally invasive colorectal surgery starting from 2011 to up to 2018. As you can see here, the open procedures are going down and the minimally invasive procedures up. If we split abdomen and the pelvic cavity into different parts of the abdomen, you see that laparoscopic procedures are going up and down. But again, starting from 2011, a robotic procedures comes into the operating theater, and the number is increasing. This figure comes from Netherlands, and they studied the uptake of robotic-assisted colon cancer surgery in Netherlands. The blue bars are laparoscopy, red robotic, and black open procedures. When you look at this, the figure, the robot stays stable and the open goes down, and the laparoscopic surgery is steadily going down in Netherlands, but laparoscopic surgery is the mainstay for colon procedures. This study is published in Minimally Invasive Surgery Journal this year, and our Korean colleagues looked to the nationwide health insurance database from 2019 up to 2023, and they look at the laparoscopic and robotic surgery for colorectal cancer. They included more than 100,000 patients, a huge number, for 5 years. And if we look at the laparoscopic procedures for only colon surgery, right and left colon surgery, the percentage is around 75%. That means that laparoscopic procedure for colon cancer surgery is the mainstay. The robotic is not yet as number increased. But the things are not same in different institutions and in different countries. This figure comes from Memorial Sloan Kettering Cancer Center. As you can see here, the blue bars are laparoscopic procedures from 2006 up to 2012. The procedures are increased by laparoscopy, but after that, with the introduction of robotic procedures into the field, and as you can see here, the colon cancer are treated more and more by robotic surgery in Memorial Sloan Kettering Cancer Center. From the same institution, they looked to the oncologic outcomes, but as you can see here, laparoscopic, open, and robotic surgeries have the same oncological outcomes overall and disease-free survivals. I would like to ask the question, laparoscopic surgery for the treatment of colon cancer is the new standard. Do you believe that this statement is right or not? From my point of view, yes, laparoscopic surgery is the new standard for colon cancer treatment. When we look at the rectal cancer surgery by laparoscopy, also very famous studies, classic color-2, a la carte, and ACOSOC, were published in 2013 up to 2019, and they also compared open and laparoscopic procedures. But at the results of these studies, there was not any statistically significant difference, and so the community started to do rectal cancer procedures by laparoscopy. We started a little bit earlier for laparoscopic rectal cancer surgery, and we published our results of the 513 patients in 2013. And as you can see here, the disease-free survival is around 67% for all stages, and the recurrence rate is around 6%, which is acceptable at that time. Then we compared open laparoscopic surgery with open versus laparoscopic surgery in almost 600 cases, and we found a statistically significant advantage of overall and disease-free survival of laparoscopic procedures. It was a little bit strange, but in our study, we found this advantage of laparoscopic surgery in terms of oncological results. Then we compared robotic surgery with laparoscopic surgery for rectal cancer. The oncological results were similar, but in robotic surgery, the operation time was a little bit longer, and we obtained more lymph nodes with robotic surgery, and the hospital stay was shorter in obese patients. The roller study compared robotic-assisted versus conventional laparoscopic surgery for rectal cancer, and the numbers in both arms are quite equal, but there was no statistically significant difference in terms of conversion to open surgery, about the complications, no mortality, specimen quality, and urinary and sexual functions. That means that laparoscopy, after this study, laparoscopy is similar to robotic surgery in terms of oncologic results. When we go back to this study from Korea, they looked to the laparoscopic and robotic procedures, open procedures in their country between 2019 and 2023. As you can see here, the percentage of laparoscopy is a little bit down if you compare with colon cancer surgery, but the role of robotic surgery is increasing for rectal cancer procedures. Again, the same report from the Surgical Care Outcomes Assessment Program from United States. For pelvic procedures, now the robotic surgery will replace, I think, in the future, the role of laparoscopy in the pelvic cavity, especially for rectal cancer surgery. The new meta-analysis was published 2 years ago, which included 32 randomized controlled trials and more than 6,000 patients. And the robotic total mesorectal excision improved distal resection margin distance and shorter length of hospital stay. In the results of this meta-analysis, the authors concluded that there is a similar oncologic or recovery parameters between treatment modalities, but there are some small advantages of robotic TME. Again, the same question, laparoscopic approach to rectal cancer is the new standard. In my hands, perhaps I can say yes, but there are some concerns about laparoscopic rectal cancer surgery because the robot is going up to replace this surgery for rectal tumors. Few words about the future of laparoscopic procedures. We know that after the introduction of a new technology, it achieved a performance advantage at the beginning and then arrived at a performance plateau 3. And we had the same for laparoscopic surgery. I believe that we arrived at a performance plateau, and then it will be replaced by a new technology. Robotic surgery in the future will replace laparoscopic procedures with the help of the machine learning. And later on, we will see, perhaps there are some young colleagues in the hall, it will be replaced by the autonomous micro-robots or the reinforcement learning capacity of the robots will take hand, and then we will not be directly in the operating theater. Because with the help of artificial intelligence and machine learning, the robots will learn to operate patients themselves autonomously, and we should learn this kind of terminologies: supervised learning, reinforcement learning, unsupervised learning, deep learning, etc. And all these new technologies will change totally the future of surgery. The future of surgery is compared with the automobile technology. Driverless cars is coming in different countries now. Also, the same thing will be for the surgery. We are in the operating theater to do the surgeries with the help of the robots, but in the future, with the new technologies, I should say, that the surgical robot will be capable to do the surgery itself with less complication, with a high precision. Because we have an evolution of surgical robotics, artificial intelligence, and interconnected ecosystems, will do a fast transformative shift in the healthcare. We know this, we saw this. The emerging technologies are the robotics, the medical imaging, and artificial intelligence-driven ecosystems, which will all helps to do more precise, predictable, and personalized procedures in the future. The advanced visualization and the new imaging modalities will enhance surgical navigation, and the procedure, when it goes to wrong part of the body, they will prevent us to the complications, to create harm to the patient. And so we will have the ability to see the unseen. Also, artificial intelligence and the data-driven platforms will increase the precision. It's really important where to dissect, where to cut, where to operate. And it will optimize clinical workflows and reduce complications in the future. Every time, every day, we are pushing the boundaries of medical technology, and I believe that this will help us to do safe, efficient, and more accessible procedures. And I believe, again, ultimately, we will define new surgical standards different than today. This is the present logo of Turkish Surgical Society, which is founded in 1929. But in the future, I believe this logo will change, and the robot will be the mainstay of the logo. Thank you very much for your attention.